Hello, good afternoon, everyone. Thank you for joining us today for our event today, Implications of Colonialism for Disease Outbreak Response in Black Communities. I'm Rebecca. I'm the Institute Coordinator for the Harriet Tubman Institute. Welcome. I will pass it on to Henry, who will be moderating the event today.
Thanks, Rebecca, and welcome, everyone. Good day and welcome. Before we get underway, I know we have a bit of a protocol to observe, and that is the reading of the land acknowledgement. And do we also have Dr. Meander with us today to say a few words, or do we get right into reading the land acknowledgement? Rebecca, do you know? All right. I believe Rebecca is on the phone. So then, welcome everyone. Welcome to today's presentation. Without further ado, I'll ask Sharon to read the land acknowledgement, and we'll get underway.
Good afternoon, everyone. I will be reading a land acknowledgement penned by Daryl Bowden in March 2021. Toronto sits on the shared traditional territories of the Anishinaabeg, Haudenosaunee Confederacy, Huron-Wendat, and the Mississaugas of the Credit. This is the land of the Dish with One Spoon Wampum Belt Covenant, one of several treaties which bind us to share the treaties and protect the land that is known as Turtle Island. We are also acknowledging subsequent Indigenous nations, Europeans, migrants, and those of us who came here involuntarily, particularly Black and African Canadians, brought here as part of the transatlantic slave trade. We respectfully acknowledge the current caretakers and ancestors of these traditional territories today in the maintenance of peace, friendship, and respect. This land acknowledgement differs from those you might have heard before. Does have its basis in a theme that is central to reconstituting the relationships between Indigenous people, agents of Canadian state, and Black populations in Canada. We are here today, not as settlers, for while Blacks in Canada have been in this country for over 400 years, and we have been beneficiaries of elements of colonialization in many ways, we are not its purveyors. We as African people have not violently disposed Indigenous people in imposing our language, systems, institutions, and/or customs. And we have not forced assimilation of Indigenous peoples in culture, religion, and/or social practices. Given that Canada's colonial conquest of Indigenous peoples and lands are largely funded through the spoils of enslaved African labor, this reframing of relations is part and parcel of the project of reconciliation and reparations. This acknowledgement also reminds us that we each have different relationships to the land that we live on. And depending on our ancestries and where we sit in relation to the struggles for justice occurring on this land, we must acknowledge our place in its protection in a way that is true for each one of us. Miigwech.
Thank you very much, Sharon. And at this point, I'll introduce the panelists, who are Drs. Harris Ali and Yvonne Simpson. I'll begin with Dr. Ali. Harris Ali is a sociologist at York University, teaches in the areas of environmental sociology, disaster and emergency management, social theory, and environmental health. His research focuses on how the interplay of social, political, and environmental factors promote emergence of disease outbreaks in environmental disasters, as well as how this interplay influences the response to such phenomena. He has conducted various studies based on extensive fieldwork on different types of infectious disease outbreaks in various parts of the world, including E. coli in Walkerton, Ontario, tuberculosis amongst the homeless in Toronto, community-based responses to Ebola in Liberia, Sierra Leone, and the Democratic Republic of the Congo, with Doctors Musoka Fala and Joseph McCarthy, and with his longtime research colleague, Roger Kyle, a comprehensive study of the 2003 outbreak of SARS in global cities such as Singapore, Toronto, and Hong Kong, which culminated in an edited volume of SARS, Networked Disease, Emerging Infections in the Global City, Wiley Blackwell, 2008, that has recently been recognized by the Canadian newspaper of record, the Globe and Mail, as one of the, quote, top 10 books that offer lessons from past pandemics, end quote. His most recent book, co-authored with Roger Kyle and Creighton Connolly, is entitled Pandemic Urbanism, published by Polity Press, and focuses on the disease ecology and socio-political dimensions of COVID-19 and other infectious diseases under the conditions of contemporary globalization and heightened urban inequality. And that is Dr. Harris Ali. We now go to Dr. Yvonne Simpson. Yvonne Simpson holds a BA from York University, M.Ed, University of Calgary, and a PhD from York University in critical disability studies. Her research interests examine the historiography of records of accountability of First Nations peoples and racialized immigrant workers. Simpson's presentation invites reflection on the nation's historical reliance on a transnational, color-coded system of labor force selection, while maintaining a system of exclusion in accounting for those who experience disproportionate levels of injuries and disabilities. Many questions are prompted, including, how do we learn about who bears the burdens of harms in the nation's workplaces? What past administrative record-keeping practices influence current policies, such that a cycle of deep cuts and unhealing wounds are perpetuated in the messy business of workplace health and safety? So again, welcome everyone. You've heard the bios of our two panelists today, and we are scheduled to go from 12:30 to 2. I am anticipating that the presentations would take about an hour, maybe a little more, and that we'll have a little time for some Q&A. Without further ado, I present to you Dr. Harris Ali.
Okay, thank you, Henry, and thanks everyone for joining in today. Is everything all right in terms of seeing the screen and hearing me?
Yes, it is. I can hear you quite clearly.
Excellent. I'm going to enlarge the screen. There we go. All right. Okay, so I think we're good to go. So I will begin. So today, what I'll be talking about is the implications of colonialism for disease outbreak response in Black communities. Okay, and this kind of cast a broad net, as we'll see, and I think it's necessarily so that we have to do that, because the impacts of colonialism are far-reaching and pervasive, and many times taken for granted and not obvious. So it's important to interrogate this from a sort of broader perspective, and that's what I hope I'll be doing. So the outline for the talk is, first of all, the guiding question is, how were the impacts from the pandemic and other disease outbreaks on Black communities influenced by the legacy of colonialism? Okay, both in North America and in Africa, because those are sort of the sites that I myself have been doing research in. Okay, so that's the main question. As I said before, it's a very general question. And then as the talk begins, we'll get into the issues of what is colonialism, post-colonialism, and in relation to infectious disease, because it has a long history in the combating of infectious disease and imperialistic expansion and colonialism. The two go hand in hand, as we will see. So then fast forwarding from the history of colonialism to sort of, I guess, more post-colonial days, like contemporary times, you can see how colonialism impacted, for example, the current pandemic. Okay, and we could go on all sorts of effects of colonialism on the pandemic response and how the pandemic unfolded. And we'll just get into a few of the issues that arose, specifically vaccine nationalism, vaccine hesitancy, and the spatial distribution of COVID. Okay, and if there's time, I'll go on to sort of more recent research that I've done on applying the work of Fanon with respect to the Ebola outbreak in West Africa. Okay. All right. So to begin with, colonialism and infectious disease, this is an area that the colonizers have always been interested in, largely from kind of self-interest too, because as the colonizing powers go into other lands, they wanted to protect themselves from these so-called neglected tropical diseases. And so, scientific establishments and scientists from the colonizing powers went to work to study these neglected tropical diseases. Now, as we'll see, this has had a lasting impact on how even infectious disease outbreaks are dealt with today. Now, in this picture is a picture of Dr. Ronald Ross, who discovered what causes malaria and how it was transmitted. Dr. Ronald Ross, he was a British expat. He was born in India, and he started doing research there on malaria. Okay, in Calcutta, 1899 to 1902. Then he had sort of discovered the plasmodium, the parasite that causes malaria, but he didn't know the host vector, like how it was being transmitted exactly. So he did subsequent research in Freetown, West Africa, where he discovered a particular type of mosquito would carry this parasite. Okay, now this particular type of mosquito, Anopheles mosquito, was a strain of mosquito that needed stagnant water to reproduce. The larva would be laid in the stagnant water. Okay, so obviously to sort of stop the transmission of malaria, you needed to deal with these pools of stagnant water, like in rocks and in ditches and in containers and so on. Okay, so two strategies were developed to deal with this. The first strategy, okay, so we're looking at Freetown now, was to sort of drain the places where this water collects. Right now, in the case of Freetown, it was very difficult to do this sort of drainage activity because the sewage infrastructure, the drainage infrastructure simply wasn't there. Okay. Now, the other way to deal with the malarial transmission was that, people realized that the mosquitoes would not survive in sort of the relatively thinner air and cooler air at higher altitudes. Okay, so knowing that, one of the ways to deal with malaria was for people to move to the higher altitudes, higher in the hills, right? But when I say people, what people am I talking about? Who are the people that could protect themselves from malaria? right? And, you know, I don't have to give you the answer to that question. You were well aware of that, right? So if you look at, for example, Freetown, right? It's a town in Sierra Leone, and you can see the hills, and at the top of the hills are basically where the colonizers lived. They put up fans and things and had a little bit of protection from malaria, right? Through the century, you know, the informal settlements have formed on the hillsides of these hills. But in the earlier day, it was these areas at the top where basically the white people, the colonizer, lived and had relative protection from malaria. Okay. Now, the other part of this is that the whole city planning was influenced by these sorts of ideas of how to protect yourself from infectious diseases. And the thing was, city planning in the colonial times was such that it meant that investment was not made in the, you know, transportation or service infrastructure for the people. The infrastructure investment was made so that you could extract resources. So certain areas of the city were underserviced, and these later become informal settlements, the so-called slum areas, these underserviced peripheral areas of the cities that were neglected. Right. And as you know, it doesn't take a big jump in logic to realize that, you know, the informal settlement conditions where you don't have infrastructure, where you have people crowded together in high density areas, where you don't have like proper sanitation and all that, these, you know, increase the risk of disease. Okay, but as you know, I found out with my colleagues in West Africa, yeah, it may increase the risk of disease, but people for a long time, when they realize that the state is not there to support them, have to develop their own means of survival. In other words, what they call now community-based strategies. And the people, you know, were quite adept in the case of Ebola to give a good response. But this is something that we can talk about later. Okay. All right. Now, the other issue here is that I want to talk about is what's called the spatial and social distribution of risk. We already sort of referred to that in terms of who lives where and who has, you know, a greater risk of the infectious disease and who doesn't, right? But you can expand that logic more generally. You know, that one of the areas of research that I look at is disaster research and disaster management, and I teach in that. And two very important case studies taught in that course deal with the unequal impacts of disasters, and this is the Chicago heat wave and the Hurricane Katrina, one of the most extensively studied disasters. The Chicago heat wave, you know, you would think that a heat wave, the extreme heat would affect everyone equally, right? But that was not the case. In Chicago, the death rate amongst Black people was way higher than it was amongst the Hispanic population and amongst the white population, right? And so why was that? And if you start doing the investigation, as Eric Kleinenberg here did, he finds that there's a pattern, right? That the single occupancy residency places that many elderly Black people live were places where people were at higher risk of suffering from the effects of heat. Okay, for example, you know, they couldn't afford the air conditioning, and then the advice given to them was to leave the windows and doors open. Right. But if you're living in a neighborhood as a frail elderly person, you know, is it a wise idea to leave your windows and doors open? The other advice was to go to cooling stations. But again, you know, a long walk to a grocery store where it's cooler may not be the best thing to do in certain neighborhoods. Right. Right. On the other hand, in the extended family sort of situations of the Hispanic people in Chicago, the extended family provided a lot of support. Right. But anyways, I could get on and on about this. Kleinenberg writes a lot about how sort of neoliberal policies where there was check-ins on people who were socially isolated were being squashed. Church groups that used to check in on the elderly were no longer in functioning and these sorts of things. But the point is there was a spatial distribution in the mortality rate from this disaster. right? Now, the same thing can be seen with Hurricane Katrina. Historically, where the people who owned slaves would live are in those higher areas that were less prone to risk, right? Whereas those who worked on the plantation, who were the slaves, worked in the areas that were prone to risk. And as the city evolved, that spatial distribution is reflected in sort of the rich areas and the poor areas of New Orleans, the Garden District versus other districts, right? So there is a spatial distribution of risks, which is important to take into account, okay? Yeah, I'm just watching the time. Okay. Now, getting back to sort of colonialism and infectious diseases, one of the discourses that was going around circulating as the colonizing powers were encroaching and colonizing parts of the world was a tropicality discourse. Okay, this is a colonialist discourse which represents non-Western regions of the global South in ways that benefit the West at the expense of other regions. The colonial perspective on health, this sort of tropicality discourse, was based on an essentializing view in which differences such as health disparities are attributed to essential differences between people, like genetics or things like this sort of explanation. And then based on this type of understanding, it was argued by the colonizer that if a disease disproportionately affected certain populations, it was because the people were intrinsically different, biologically, physiologically, genetically, culturally, which predisposed certain groups of people more or less susceptible to particular diseases. So this is based on an essentialist ideology, which served as the rationale for various exploitative and racist colonial practices, ranging from the British white man's burden to the ethical policy, quote, ethical policy of the Dutch to la mission civilisatrice of the French, and so on. Okay, this is based on a tropicality discourse. Now, the essentializing perspective that we just went over served as the basis for othering. They talk about othering all the time these days, right? And it has an origin in this colonizing discourse, okay? Otherness was expressed through the discourse on tropicality, where Europeans from the 17th to 20th century distinguished themselves from the areas they colonized by emphasizing the different geography of the area, flora, fauna, climate, topography, and also culture. So with this tropicality discourse, others were seen as a threat to the Westerner. And this was the rationale, this idea of threat of the other was the rationale behind the establishment of the London School of Hygiene and Tropical Medicine in 1899, when Dr. Ronald Ross was doing his work, okay? In later post-colonial periods, the colonial discourse of tropicality and infectious disease and othering was extended to other sources of, quote, threat, rather just than infectious diseases associated with the tropics. Okay, or what's now called the global South. So if you look at things, what's gone over the history into the more recent history, you can see that, there was a tropicality discourse during the colonial period, definitely. But then after the Second World War, as nations were getting their independence from the colonizer, the threat became redefined, but still based on an othering process. It was a threat of poverty, and that, the desperate people from the global South would come and invade the global North, this sort of mentality, right? And so that the cure was not Western medicine as it was for infectious disease. The cure, the cure was investment in aid. Okay, now that later on, the threat was this idea of hazardous natural disasters, right? And the threat would be sort of addressed by Western science and, quote, relief, right? Then post 9/11, the othering and the threat got redefined once again is in terms of criminality. And the cure to deal with the so-called Islamic terrorism was Western democracy. But it's always based on othering and essentialism, which has its root origin in the discourse on tropicality. So what's happening today then? Okay, over the last quarter of centuries, and you're well aware of this, you know, there's been an onslaught of emerging, new and re-emerging infectious diseases. And here is just a list of them. And I could think of more. These are on the top of my head when I was making up the slide. COVID-19, of course, Zika virus, monkeypox, Middle Eastern respiratory syndrome, Ebola, Lyme disease, HIV, AIDS, hantavirus, pulmonary syndrome, antibiotic-resistant TB, mad cow disease, hoof and mouth disease, West Nile virus, Clostridium difficile, E. coli, 015787, SARS, avian influenza, swine flu, and that's just few of the diseases that have come up in the last quarter century. I'm not going to get into the question of why that has happened. That's a different discussion, which deals with the environment and health and changing relations to the environment. But what I will get into is the social dimensions and the political dimensions of this. Andrea, I have to ask, how long do I have until?
Well, it's now 1 o'clock, and I would say at least until 1:15, which would
Okay.
give you approximately half an hour, and Yvonne would have approximately.
Okay, that's great. Yeah, so what was happening as these infectious disease onslaught was unfolding was that infectious disease became redefined as a security threat. Okay, a threat to national security. And there's certain reasons why this became a prominent and influential sort of discourse, right? There was a big conference held about emerging infectious diseases by the lead virologist and microbiologist in the United States. And they put out a report around the same time in the 1990s. There was this popular book, The Hot Zone by Richard Preston, and the Coming Plague by Laurie Garrett, which raised the profile of emerging infectious disease and the need for securitizing that. At the same time, this very influential journal came out by the Centers for Disease Control. These are covers from the journal that's put out. You can see it's on different topics every month or whatever: women in infectious diseases, antimicrobial resistance, foodborne infections, right, zoonotic diseases, and so on. Okay. And the securitization of infectious disease threats is clearly seen if you look at things like this on the left here. This is a CIA report after the SARS outbreak. SARS, lessons from the 21st century. So all of a sudden, CIA and security agencies are how you say, interested in infectious diseases. If you look at the equivalent, like sort of the policy, national security policy of Canada, there's whole sections, chapter on infectious disease as a threat, right? It enters the popular mind. This is on the cover of the New Yorker magazine about anthrax threat, right? Political science journal like Foreign Affairs starts taking up the topic of infectious diseases, right? Political science does, right? So this ideology is spreading, you know, so you have the securitization of public health occurring as more and more funding is coming from the Department of Defense in the US and from the military to look at infectious diseases as part of the securitization process. So what is happening in the more recent context? Well, vaccine nationalism. You see, the idea that, oh, we have to protect ourselves and sort of kind of monopolize the vaccines that are out there in order to protect ourselves. This is based on the securitization kind of aspect, right? And you know, oftentimes this ideology is protected by these intellectual property rights, which protects the profits of the pharmaceutical companies at the cost of human lives. It prevents places in the global south which have the technology to produce vaccines from being prohibited from doing so because of patents. Okay, so even those vaccines that are locally produced in the global south are being shipped to the west instead of being available locally. This is vaccine nationalism, a product of sort of the legacy of the colonial past and securitization of disease. Right now, vaccine hesitancy, you know, and I use hesitancy in quotes, right, because it's a misnomer. There is a reason, and a valid reason, why people are how you say, suspicious of vaccine, and it has to deal with, again, the colonial past and the more recent past, right? You know, one of the things is that nowadays you have a lot of clinical control trials being done in places in the global south, like Africa and India, because the ethical issues and patient protection and these sorts of things can be violated without meeting sanctions. And people know that, right? There's a deliberate and instrumental use of disease outbreaks by Western medical corporations and academic institutions to test vaccines without proper consent from the people. So obviously, knowing about situations like this will lead to deep-rooted distrust of Western medicine and Westerners in particular, right? And in fact, during the COVID pandemic, 2 medical researchers from the global north, France, proposed that COVID-19 vaccine trials be conducted in Africa, right? It's outrageous, right? It's going to the marginalized and taking advantage of their situation. So there was a well-known outbreak 1996 of meningitis, right? And a clinical control trial was being done in an unethical way, right? That's 100 of the patients were given something, a known medicine that they knew to work, and 100 people were given an experimental medicine which wasn't known to work, right? And the company, this was Pfizer, said, well, we got the consent of the people, but investigation showed no, that the consent forms were kind of forged and so on, right? This is, so, you know, this is the situation and circumstances in which vaccines are developed and being implemented, right? So vaccine hesitancy under that context, well, that kind of makes sense, doesn't it, right? You know, and then amongst the Black community in Toronto, right? Let's look at some of the statistics. 83% of people with a reported COVID-19 identified as a racialized group. 55% of reported cases in Toronto were living in households that considered to be low income. In America, on average, Black Americans have been dying of coronavirus at nearly 3 times the rate of white Americans. In the, oops, I'm trying to go back here. In the UK, like the rate's 4 times the Blacks deaths than the white deaths, right? Now, in Toronto, if you look, and we talked about the spatial distribution of disease and risk. If you look, this is the distribution of COVID. Where are the areas in Toronto that are most effective? Well, they coincide with the areas that are the Black areas, right? That's clearly the case. And then if you look even more into things, the neighborhoods that have the most Black residents, this is on the bottom here, have the highest rates of COVID, right? So areas like the beaches, which the Black residents only form 2%, the COVID rate is very, very low, right? The areas which are Black, the COVID rate is very high. So you have a spatial distribution of risk. Clearly is the case. The data shows that over and over again as the number of COVID cases go up, as the percentage of the Black people go up in the particular neighborhoods in Toronto. Clearly the case. So, you know, we can ask the question, what accounts for this spatial distribution of COVID-19? And again, the answer is, it's a legacy of colonialism in the way that it impacts certain groups of people. The Black people, the life chances and life outcomes of Black people are constrained in systematic ways because of their ethnic racial identities. Black people are more likely to be unemployed, occupy low-paying frontline work, and overrepresented in overcrowded low-cost housing. Okay, so the claim that being Black is, quote, a pre-existing condition for a global pandemic is not far-fetched at all. Okay, many of the Black people, of course, are involved in essential work, right? And therefore the risk of exposure is much more, you know, but there is hope, right? Grassroots sort of community-based approaches like pop-up clinics, members visiting people at home, door-knocking campaigns, mobile clinics, outreach activities were successful in getting the COVID rates down, okay? We discussed this in our book a lot, the spatial distribution of COVID in the Black community and the South Asian community in Brampton. So this is just a plug for the book. And I've run out of time, so I don't think I can get into this about work on the France Fanon, perhaps for another time. Okay, thank you for your attention, and I turn it over to Henry for Yvonne. And I'll stop sharing.
All right. Thank you very much, Harris. And just in case people have questions or comments, I suggest you just hold them until the end after Yvonne has presented. And then once you have those questions, you may say to whom the question is directed at, or whether the question is, open to anyone to answer. So now we go to Yvonne Simpson. Yvonne, it's all yours. Are you there, Yvonne? Okay.
You are muted, Yvonne.
That's
I went to share before unmuting myself. Sorry about that. We'll just redo that. Can you hear me now?
yes, clearly, and
Okay.
it's all yours.
Okay, great. Well, thank you, Harris, for that very interesting presentation, which provides a thematic connection to what I'm about to speak to. And in common, this is about colonization, right? It's Black History Month, and we are fortunate to be here at the Harriet Tubman Institute. And the Institute, I must say, thank you very much for giving me that support as a grad student and undergrad student over these years. And so here I am at this pivotal time, Black History Month, celebrating and yet, reminiscing and in thought-provoking discourses about our struggles, our achievements, and what the future looks like in this area of the implications of colonization, and what has been, for the main part, a historiography of a color-coded system of health inequities and disability exclusion. And I think Harris would agree, based on the theme of his presentation, that this is a continuous site of struggle for Black and racialized and Indigenous peoples in Canada. So linking this to the idea of struggle and achievements, which is essentially what Black History Month is about, let's examine this graphic image on slide 2. We have the presentation of an African-born man who is presented here in an image that I cannot attest to whether or not this was his real image, because there are many images like this with the name Onesimus attached to it. On the left, he's credited with introducing the idea of a vaccine for smallpox. He was born in Africa, was enslaved by a minister, a Puritan minister in Boston. And when the smallpox epidemic broke out in the 18th century, Onesimus went to the enslaver and spoke about what he had learned in Africa about curative measures with diseases such as the smallpox. He mentioned that they would take a portion of infection from someone else and provided it through leaves or other mechanisms that they had available in their local community, so that the community would be slightly infected and not be wiped out. This is authenticated in the medical journals. The U.S. National Medical Journal of Medicine also has documented these exchanges between Onesimus and his enslaver at the time. This is 1721. So let's fast forward maybe 50 years from 1721 to 1778. On the right, we see this escaped slave ad, which in Canada was a very common practice, similar to the United States. When someone went for their freedom, the machinery of the print industry went into full operation to advertise, to bring back that runaway person. In this slave ad from 1778, placed in the Quebec Gazette. I'm a researcher, I'm an archivist, so I look for our histories and our interactions in terms of occupational health and safety. This poster came to my attention because others might look at it from the interest of purely history and what has happened. I look at it and I seek out evidence of disability or what happened to African ancestry people once they arrived in Canada in chains. Although no ship launched on these shores, the transnational routes within North America, between the Caribbean and North America and the UK, brought enslaved people here to these shores. And we have evidence of this because here we have this ad placed in the newspaper in Quebec, which said that Joe was born in Africa. He was about 20 years of age. He was about 5 feet tall. Now, imagine the detail that we have about Joe. Keep that in the back of your mind as I talk further later on about the lack of data collection regarding occupational health and safety and racialized people. But this ad from the 18th century has all kinds of details about Joe, how tall he was, what markings he had on his body. So here's this pivotal point that links Onesium and Joe. Because of what he did, Joe survived smallpox. Joe has smallpox. It says in this ad, he was marked with smallpox. He speaks English and French tolerably, and he went missing. His clothing is described in detail. And the fact that Joe was a skilled person and worked in the printing office, but he ran away. So there's two things we need to be aware of in this period of African recognition and Black History Month. There has been a struggle and a survivability, and our skills and our resources have not only helped us to survive, it has helped the world to survive. Because now we're talking about COVID, and we can say antigens that Omniscium brought to his enslaver was one of the precursors of developing protections against contagious diseases. And part of the exclusion of our history, which is often baked in this narrative about oppression and our sufferings, yes, that is true, and it continues. But what we have contributed in terms of our struggles and survival has yet to be told. So these two people now link to our history in terms of our survival. And what we need to know, and the importance of linking this history, is what we need to do in terms of our humanity going forward. That is the central place of my research. So I will talk a bit more about what I would like to give in terms of overview in the short time that we have. We could spend about a half a day on this research, but in this brief time, I will provide a brief overview of the research that I've conducted, the context of the research, the purpose of it, and I'll sensitize some concepts. I can't get away from that because I teach, and I always have to bring to everyone in the environment some of the concepts and why they're important as we talk about these issues. And I'll share with you some of the methodologies that I went through in gathering this research and what some of my findings were in ending up on this. So looking at this in its broadest context, historically, and to the present day, Canada has relied on immigrant workers. Why is that? That reliance has been the way that the nation has grown. Its wealth, its productivity, its population. There's an interdependency with the quest for labor and how the nation has managed to maintain its growth. We know currently, based on what Statistics Canada has said, that by 2030, not very far away, the net growth of Canada will primarily be derived from immigrant workers. We know from that slide we've just seen that reliance started from the colonization period, when Black people, African people, were brought here in chains to supply the nation with its labor force. Canada, the Americas, the Caribbean, the globe was set on this framework of we need labor. Where will we get the labor? Africa was the source. And the globe and European monarchs were engaged in this travesty of putting people in enslavement for the purpose of labor. This has continued, but now we don't have enslavement. What we have is the legacy of colonization and some of the policies that have grown out of that colonization that have perpetuated inequities in occupational health and safety to this day, for which we have no record. When Harry spoke, he spoke about the spatial data where people are broadly populated. Why is it that we have for the United Kingdom and for the United States? Harris could say, this many people in the United States who were Black were affected by COVID. These many African Americans, this many Asian Americans. And it's the same for the UK. When it comes to Canada, if we listen carefully, we have to look at statistics and data from a spatial geographical perspective. Why is that? We will get to that based on what we have come to know. But one of the things that's prominent in this area of the research and the continuous reliance on racialized immigrant workers, in particular, Black people arriving from Africa, the Caribbean, historically and currently now, where we can see that 60% of the people arriving are destined for the labor market. Why do people come? For work. What do we know about what happens to them in the course of work? What happens to their health and safety? While we're recruiting, setting up systems and policies to ensure we get the best, the brightest, and the most adaptable people to Canada, not one scintilla of policy framework is going into tracking and tracing how are these people doing in terms of their health and safety in the workplace. Think about it. If we're recruiting and attracting people for mostly the purpose of work, it would fall to reason that we would want to know what happens to them in the context of that work. We don't know, and we cannot speak to that from any lens, other than to know they bear the brunt of the burden of being in the work area where work is precarious, where work is more dangerous, where work is more injury prone. That much we do know. Who are they and how are they injured? We will never be able to segment or segregate that data. We know that this picture of changing as to who is arriving in Canada has changed. In the early years, it was primarily from Britain, the white countries. Let's just say it what it is, Europe. Currently, people are arriving mostly from the Caribbean, Central and South America, Africa, and Asia, racialized immigrant workers. What has been at the governance foundation of attracting, taking, and keeping racialized workers in Canada? Let us start with what was at the foundation of New France. At the foundation of New France, the Code Noir, my French is not so good, so I'll just say the Black Code, which is how it was commonly referred to in English. The Code Noir was enacted and was utilized for the governance of enslaved workers. So the Code Noir itself, as you see pictured here on this slide, it has 60 articles and it regulated the life and death of those who were enslaved from life to death from the time they arrived. Now the Code Noir, let's not have any mistakes about this. It was brought from France to govern the territories held by France, Haiti, Guadeloupe, all these Caribbean countries, and later introduced in New France, as we know, was colonized. To Harris's, the colonization that is still carrying on in disease, how people live, how their lives are regulated, how they experience disparities. The Code Noir was introduced for the governance over bodies, and we see the code acting out today in police shootings, where people must live, regulated in terms of that spatial geography. You live in certain areas. The Code Noir is perpetuated from this colonization edict to this very day, more so prominently in the area of occupational health and safety. And I'll explain why. So in 1685, King Louis XIV brought about this edict. We don't have any evidence that it was formally proclaimed in New France, but it was social customary law used. And we know this over several cases of the enslaved persons posters. Grab them, find them, torture them. If they escape once, if they escape twice, the Code Noir would outline what punishments, what tortures, what could be done to the bodies of Black people if they dare to try and escape a life of enslavement in New France, Canada. How do we know how many people came to New France or who was there upon the time of colonization? Well, there's a lot we don't know, but there are some things that we do know. So here is the thing that all Canadians can be proud of. The first census taken in North America was of New France. The intendant of New France, Jean Talon, conducted this census at the direction of the king. And here's a sample on slide 6. We see his handwritten census. He went about diligently to every household in the settlement and accounted for every settler. Okay, if I was in my class of 20 or 30 people, I'll say, who was not accounted for? Can we guess? Who was not accounted for in this census? Okay, I'm going to tell you because we have limited time. Talon did not even make an asterisk about the thousands and thousands of First Nations Indigenous people surrounding the area. No document, not even a footnote. He sent his census record back to the king and all is well and good. There's not one record of, I have a question about this or that, because I'd heard that there were these people who lived there before we arrived. Nothing. He tabulated and accounted for the settlers. He also identified 401 servants. The French had an aversion to say slaves or enslaved. They would say savages, or servants. But to admit that there were enslaved people was not something that the French wanted to do. So we can know that since the foundation of New France, there was an accounting for the citizens, no accounting for the other, or those who were servants, or their identities. But the records were diligently kept, nicely handwritten, and sent off to France. Now, for the purpose of my research, why did I become interested in this? I have worked in disability services for most of my career. And one thing that became evident to me as I was seeing more and more people presenting themselves, there was something different about those who were injured and hurt. They had identities in terms of oftentimes being racialized, oftentimes not speaking English, or English was first language, or the types of work they did would often determine the extent and the excessiveness of that injury. I became very curious about this and began looking at our occupational health and safety data. What does WSIB say? Is there any data about people and their ethno-racial identities and their injury rates? I discovered nothing could be found. I was a bit surprised because it was a curiosity out of something I was observing and I wanted some validation. Nothing was there to tell me this. So I went to look. So because that did not exist, I began to question, and my research led me to these questions. I wanted to determine the extent of racialized and Indigenous peoples' contributions and their work-related disabilities. What was happening there? I wanted to determine the availability of demographic data in this regard, and I wanted to determine the impact of the historical legacies of these records, how they were impacting people's lives. And I furthermore wanted to determine the sources, if there were any, of collection of race-based data on immigrant status, racialized race-based data. There is none, I can tell you this. I'm watching the time. Sorry, how much time do I have left? Before going further, we need to contextualize these discussions around some concepts, because we often talk about these fleetingly, but let's talk about why this is important. Health equity is important. Health equity equals the nation's health, right? If we don't have equity for those who are on the front lines, as we see the crisis now in healthcare, as we see the crisis now in the workers who are considered essential workers, there's a breakdown. We have no idea what is happening to these workers. Health equity means equity for all individuals should have fair opportunities to the fullest potential of their health and for the protection of their health. Health inequity, on the other hand, will lead to differences in terms of access to justice and healthcare, and inconsistencies in terms of population groups, and plausibly some of these inequities that could be ameliorated if we only knew more by having the data, by having the statistics, which in Canada we don't. We purposefully do not disaggregate data based on race, ethnicity, immigrant status, even though this is the primary reason why we're recruiting people to come to the country. Historically, they were brought in chains. Now we have forced migration because of economic conditions. Still, no data being kept. Racial inequities, on the other hand, results in structural racism. It's about structural racism stemming from these historical and colonial issues that have happened over time. Politically, institutional racism due to power relations have worked in a cumulative way to impact us then and now, continuously, because these patterns have continued from the time of the Code Noir, where anything could be done to Black bodies, and it is continuing. Put them in the most dangerous work, police them in ways, put them in communities where we can keep an eye and know where they are. We need to go and get them and get the data on the crimes they're committing. But when it comes to health and safety, we have nothing. Equity is a principle we're all familiar with, and these concepts are variously defined, but the principle and the process for promoting fair conditions for all. And we have to recognize not everyone has equal distribution or equal access to equity. And this is from the Council of Canada for the Arts. These ideas are intersected with disability, health, and illness, because when you work and you have no choice, you have no options, you don't have access to vaccines or healthcare, you don't have time off for taking care of your health, you don't have space in which to socially isolate, disability is produced out of these occurrences, and it's reproduced again and again. We start with the healthy immigrant who must go through a sanitized examination to be declared perfectly healthy to enter Canada. And we saw this with the farm workers who were coming in as essential workers, had to go have a clear bill of health, isolate, arrive, and then what happened? They came into these cramped quarters. What do we know about these migrant workers? How do we learn about their plight in Canadian society once they've arrived? no data, no statistics. And if we really want to know, we may learn something on TV or in the newspapers. Think about the newspaper and Joe running. That is how we find out about something has happened to a worker in the newspaper. So we see these colonized constructs perpetuating then and now. We look at the models of disability, we see that we start off with a model of disability with a moral model. We should have care for people, and therefore disability was seen as sort of an affliction. They must have done something to bring this on to themselves. Or it could be the good side of, God will take care of this person in their state of having a disability. So that's the moral model. The medical model emphasizes looking at the person in terms of their sick role. Mind you, if Joe was sick, his enslaver would probably find a way to make him work, imprison him, torture him more, or Joe may end up dead. We don't know what happened to Joe from that poster, by the way. What happened once Joe was caught? We don't have any evidence of what happened with Joe. We only know he ran away because of the poster. The biosocial model tells us, which was generated in the 70s by a psychiatrist, Engel, who started to encourage us to look at disability in terms of the complex interaction between people and other factors, other identity factors, that health in of itself should not be seen purely as a medical thing. So we need to look at where people live, what were their quality of life, what is happening to them, look at the social aspects of one's life as well as the biological aspects. And that began to take shape in terms of defining disability. Currently, though, disability, which is the model that has gained strength out of advocacy, to move away from this idea that disability resides in the person, we must fix that person. Disability advocates now say disability is the interaction of the person and the environment. So if you made corrections in the environment, if you provided ramps, if you provided reduced attitudinal barriers so that I could be accommodated and have an accessible workspace, there would not be a problem. So this is the idea of the models of disability that we have seen change over time. What is missing in this model is, where do African ancestral people fit who have the layers of racism, who bear the burdens of having been brought here through this historical legacy? We don't have an extension of this model to represent colonization and the infliction of harms, the deep cuts, and the unhealing wounds that have plagued the nation since New France in its creation. My study went into an inquiry of looking at several areas, including the legislative framework, including the performance of occupational health and safety, and I used different sources of data points. I researched the literature to find out the evidence and the presentation of disability and the contributions of racialized immigrant workers historically into the present day. I looked at documents to find evidence because I could not find any evidence in our current ways of looking for data about people in occupational health and safety. The historiographical approach was the only approach that I could use to get to the truth. After looking at all of those documents and realizing I don't have information here, I cannot come to a solid conclusion about why this is. I had some ideas, but I'm a Yorkie, right? So you're told, go out there and find out some more, right? So I went to speak to key informants across Canada, 27 of them, who are specialists and experts in occupational health and safety. And they informed about why this and why it isn't. The overarching finding that I came to, I'm going to try and wrap up here, seeing as I'm overdoing my time. The overarching finding here is that in Canada, we do not capture occupational health and safety data based on demographic identities such as race and nationality, because data belongs to the Crown. The Crown determines what shall and what shall not be connected. And we have had the history of Talion, who started the census data to only capture people from a colorblind perspective, or a perspective of who mattered in the community. So we will collect generic data, men, women, youth, older people. And if you happen to be in one of those categories in your occupational health and safety life, you will be captured. But we will never know what identity you are in your community bearing the brunt of occupational health and safety. And it carries on today. So I propose that what we need to do in the future, looking at this model, is to begin this accounting, because we have 2030 coming on our heels, and we still have no way of charting where or how people are on the spectrum of incurrence of occupational health and safety. We do know that there's some theoretical frameworks that can help us to understand, from critical race theory, from ethnography, what happens to people in environment, from critical disability studies. We have ways of analyzing this theoretically from thought critics, but we have no solid data, and we need to do more in the areas of inquiry on inclusivity, of legislative frameworks, and to further expand this into performance indicators where racialized people are concerned. I'll end here, and perhaps for what I haven't spoken of, I can use the rest of the information. Thank you.
Thank you very much, Yvonne. And again, thanks to Harris as well. We have been presented with, oh my gosh, I would like to use the metaphor and say a sumptuous meal, but we would not be able to digest some of the ingredients in this meal, so I would not use that metaphor. Food for thought, maybe. So now we can open this up to those who would like to make comments, those who would like to ask questions. And again, you may raise your hand, you may use the technology that we have, or you may do that physically. Once I can see you, then I will acknowledge you. And once you have a question, you may direct it to Harris or Yvonne, or you may make it general. And let's see where we go from here. Before the questions, I couldn't help but notice the saying that the more things change is the more they remain the same. And listening to Harris and then Yvonne, they seem like, I'm tempted to say, two bookends of the same issue, but then the issue continues, so there seems to be no ending. And I'm sure that we'll have some very interesting discussions as we go along. So now, thanks again. We are open for questions, comments, and members of the audience, please feel free to ask your questions or make your comments. You may use the chat if you wish, and let me just make sure that I can see everyone. I have to go back to the screen. Okay, there we go. And I don't see any hands up at this point. Oh yes, there is Amanda. Amanda and Kara.
Yeah, amigo, it's a hard name. Nobody can say it. Amanda's fine. Yes, well, first of all, fantastic presentations. I'm sad that I came a little bit while Professor Harris-Ali had already started. But thank you both very much for very interesting and very compelling and touching presentations. I would love to get your thoughts about So my background or what I'm a student at York University, and I'm doing psychology, but I'm doing critique and historical studies and theoretical studies of psychology. And a lot of the things that I'm looking to research, of course, have a lot to do with memory, present, and future when it comes to Black population and Black health. And all of this has to come together. But one of the things that I've been tackling with, and maybe you can let me know, is kind of when all of these kind of information is gathered, when we do all of this kind of research, what are the ways how does that impact, and how can it impact either policy or the way that we look at health or the way that we do care? I think these are very important. When I'm listening to both of you, a lot of things are validating where it's like, yes, that I can see this happen and this makes sense. But yes, I'm just wondering, like, what are the ways that we can use the kind of research that you're both doing to resist certain things, but also to educate and to change systems? It's a broad question, I know, whichever way you want to take it.
All right, who wants to jump in?
Yeah, I can jump in, Henry. That's a great question about what to do with the information and data once you have it. And that actually reminds me of something that resonated with me as Yvonne spoke and about, getting the data, because, Toronto Public Health wanted data on the Black populations and the various ethnicities in Toronto. And the federal government refused to collect such data. So the Toronto Public Health did it on their own, at their own expense, but Toronto Public Health obviously thought that such data was very important. And why did they think it was important? Because it goes right to your question, Amanda. It's like, yeah, because if you have the data, you know the areas that you need to target, what communities and what neighborhoods you need to target, and what type of resources you need to target, right? I mean, the same thing was happening in one of the highest COVID rate areas in all of Canada was Brampton, more than Toronto, more than Ottawa, which are the two second ones after Brampton. And it's largely South Asian Punjabi community. And, you needed the data to see how exactly can you target those groups, right, to make a more effective response, right? So that's kind of like a sort of general answer I would give. And, Yvonne may have more to add.
Yes, definitely. Excellent question, because it's about research utility, right? Now that we've done this research, we've made some discoveries, and the question is, what are we going to do about it? So let's reflect how research has impacted change, and that might spur some ways of how we want to use research. I can speak to what I would like to see next in terms of my research. But let's reflect in terms of occupational health and safety specifically, how it has changed, right? In 1913, the workplace safety and insurance legislation was enacted. And it took someone being appointed to go around and study occupational health and safety and how that looked across the world. Do you know why? Because it was the industrial age. People at that stage people were losing their arms, they were becoming traumatically injured, and workers were turning to suing the employers to be compensated, because at the end of their horrific injuries, they were impoverished. They didn't even have money to go and file these suits. But those who were becoming successful, it became problematic. So now we had to do something about occupational health and safety. When the occupational health and safety and workplace safety was enacted, there was the formation of this idea of a shared responsibility. Workers gave up their right to sue the employer in exchange for being part of a public insurance scheme, so that if they were injured, they would have compensation. That took data, that took observation, that led to action. Now that we have this scenario of, I'm listening to Harris, the federal government said, no, we're not going to collect that data. Why would you not want to do that? You're afraid you're going to find out something that you must address, right? We've had in occupational health and safety where we did not collect data on young workers. We did not collect data on older workers. These things have evolved and they're now part of the system. So the next horizon is to say, we know something is happening in terms of racialized workers. My research, I'm hoping that if I continue to be able to find some ways to get funding to continue the research, is to let's join in a coalition. Those 27 key informants I talked to across Canada, they said, yes, you're right. We don't know what to do because, you know, it's just how the government operates. When have we waited for the government to operate and not do anything? So we need a coalition. We need to turn this information into action, and we need to build and demand that this change take place. In Spain, data is being collected. In the United States, I can tell you how many workers of Canadian nationality were killed in the workplace. We cannot break that down in Canada, and it's being done right across the border. So we need change, and it's necessary for intervention, prevention, and foster support and security for workers.
Thanks, Harris. Thanks, Yvonne. Before we go to Leslyn, I just want to make a connection here. Having been an educator for a number of years, employed with the Toronto District School Board, I recognize this same hesitancy to collect data. When data were being sought to figure out especially the effect on when the schools were being closed and students were chased out of the schools at the end of the day, when researchers asked for data to determine what was happening to these students, especially our young Black men, there was considerable pushback against the collection of such data. I think it changed later on. But I'll leave that where it is. But I can't help but make these connections as I listen to Harris and Yvonne and get a better understanding of the bigger picture. Let's go to Leslyn Gumbakomba. I hope I got that right.
Yes, you did. You did. Thank you so much. And thank you so much, Harris and Yvonne, for great presentations. To start with Harris, like I'm a first year PhD student, and I'm leaning on doing my research on the disposition of land due to extractive mining industries in Zimbabwe, which apparently people are ending up probably in slum cities around the city of Harare. I was actually very interested in the fact that, you know, building of infrastructure for resource extraction and not benefiting the people, which I'm finding very, very interesting. So that aside, I was also looking at when you talked about the tropical discourse and infectious diseases. Because I was looking at, okay, Africa, or most places in Africa, they didn't get COVID vaccine disbursement as fast as it happened in the north. But when you count the numbers of people who died of COVID, you know, in Africa, those numbers are much, much less when you look at people dying, you know, like in America, you know, New Orleans and Italy. So then things like this, that's why, you know, people in Africa started asking themselves, like, is there any need for these vaccines? Like, there's so much mistrust. And especially when you talked about, you know, when Yvonne talked about, you know, some of these diseases that happened, all these experiments, right? And you know, there's this whole issue about, you know, Bill Gates Foundation funding experiments in Africa, kind of, I don't know, producing a giant mosquito or whatever, which can eat the other little mosquitoes and you know, all these medicated mosquito nets. So it's all these issues that become very problematic. And again, in the question of othering, because even if we like the West doesn't want to admit, but Hillary Clinton had to apologize when the experiment was done in, you know, the syphilis, whatever experiment for those prisoners. I think 600 of them who died because of those experiments, right? So yes, it was very interesting, you know, to learn about, you know, the infrastructure development for resource extraction and the othering, and you know, kind of the renaming of these disasters to say, okay, now we are at disease, now we are at poverty, now we are at the hazard. What next? What next? And interestingly, Yvonne, you mentioned about the Code Noir. So I was actually saying, you know, we almost live like coded animals. You know how when farmers have got their cattle, right? And then they put these codes on them or whatever initials they brand on their animals. And pretty much we really feel like we're branded. And when we, you know, when they started introducing like all these forms that we fill in or indicate, you know, are you Black? Are you this? Are you this? Are you this? And to me, it's almost like we're being coded, right? And who knows? Like we're saying, who knows what that information is going to be used for, right? So yeah, you know, so thank you so much, you know, for those insights.
May
Thanks.
I just, yeah, sorry, may I just make one point to that, Leslie? Sorry, you mentioned
It's all right, Yvonne. Yes, go ahead.
Thank you. You mentioned the word coded and the Code Noir. The Code Noir had articles within it on what should be done to Black people's bodies should they escape, how they would be branded. For example, the Lily Fleur would be branded on someone who had escaped once or twice. Eventually, they would have body parts cut off or executed if a third time. That was the Code Noir in Canada. We're coded still, you're correct, because if you're not in the correct postal code, your chances for access to medical care are greatly diminished. Your chances of having an ambulance show up at your door if there's an emergency are greatly reduced. The chances of police descending on your community based on postal code is by postal code, how you're policed. So you are correct. Your other part of your question, I think, is there a danger to this collecting demographic data? The danger is to not do it. Because if we don't have the information, we don't know where we need to change or how we need to make adjustments so that there's fairness and equity. But yes, we are all coded, even based on our postal code.
Thanks, Yvonne. And that is so poignant because it has become so commonplace and so well integrated into our lives that we don't even recognize it that way. But it's again, the more things change, the more they remain the same. In reference to that Code Noir, in the Caribbean especially, the British came afterwards and simply built on that Code Noir. They did not eradicate it or, you know, as all of you know, legislation is never really overturned. It just remains on the books, and a succeeding set of authority figures or system simply build on that. Okay, there is some very useful information posted by Ellie Perkins in the chat session. It's a bit lengthy. I don't have the time to read all of it, but I suggest that if you wish, you may check that, check the chat and see what Ellie has posted there. Take a little bit. We're in the position where the informal sector, meaning activity governments have not, collected data about, is about 80% of economic activity in many African and Asian countries. You know, and I think that stands out. And I suggest, you check the chat and see what Ellie has put there for us. Let us, yes, we have another hand. Rachel Aarons.
Yes, thank you. Thank you, Yvonne and Harris, so much for the great presentations. I really enjoyed it. I just had a question based off of what Leslyn just brought up, and I really didn't want us to end without asking this question. So carrying on from what he was mentioning about COVID in Africa, I was wondering if you guys had any insights on what we can use to explain the lower rates of COVID contraction in Africa, or lower percentage as a percentage of the total population. Africa is a region that consists of Blacks who, just like the Blacks in Canada and the US, have been exposed to the long-term disadvantages of colonialism. So I was wondering, do you think weather plays a role, or perhaps the genetic diversity that you see in Africa sort of playing a role in, providing more immunity? What do you think is the difference there with Africa versus the or people of African descent in North America?
Yeah, maybe I can start to address that question. In some ways, it has the response would have a technical dimension to it. The differential rates between Africa and North America, with Africa being lower, there's different explanations, all partial explanations. One of them is that, as you may know, with this huge amount of urbanization occurring, often in informal settlements, the demography of the regions are changing in the cities, and in particular, the young generation. If you look at the age pyramid, it's like most of the growth is in the younger generation, right? And for many infectious diseases, there's advantages in the immune system to fight off infections amongst the younger generation. So that definitely is one thing. The one sort of neglected aspect, I would say, is that, infectious diseases in Asia and in the global south, people have had to dealt with for a very long time and have developed their own indigenous ways that have, been proven and tried for a very long time as well. They're often their informal methods of dealing with things. But, one of the things, though, and this is a more general statement, is that, when you don't have a government to protect you, when there's where there's a weak state, where the infrastructure isn't available, there's no social welfare net, there's no hospital system in place, formally speaking, then you have to resort to your own means and measures and to the informal system, right? And this is what I found in West Africa with the Ebola outbreak. You see, because a lot of the outsiders who came from the West to deal with Ebola, they were interested in the issue of controlling the disease. But the African people, were the people afflicted with the disease, were interested not in the control of the disease, but care for those who are infected. So care is what they needed, not control. And, through, thousands of years, systems of care have been developed. I mean, when the West came and established the Ebola treatment centers, at first, they were very hostile looking areas with barbed wire fence, and they weren't allowing people to visit their loved ones who were receiving care, and all this sort of thing, because they weren't responding with the proper contextual knowledge, right, of the informal system. Of course, the loved ones and the family members have to be given access under very careful conditions to care for the loved ones. That's the way it's done. That's a contextual factor. So the informal system of healthcare is underrated. And I'm not going to say that, oh, it should replace formal care. Of course not. There should be investment in the government and so on, right? But that was one factor too. For example, like with Ebola and also with COVID, you know, informal systems of providing food for those quarantined, right? For conveying messages and communication for those quarantined, you know, things like that were arranged on an informal basis to set up water stations and sanitation stations so people could wash their hands, all done informally by faith-based groups, community groups, educational groups, and so on. So that's one dimension, this so-called care community of the informal sector that also contributed to a lower COVID rate. You know, and all, you know, in some places they dealt with Ebola, now COVID, so the informal social infrastructure was already in place. That was another thing. The third thing is that, you know, at the beginning of the pandemic in Africa, some people had the idea, that COVID is an elite disease. It only affects the international travelers who are doing business or going for education or conferences. And then it's a disease for them, the elites in society. Most of the population need not be worried about that. This was the idea that was going around. It's to a large extent false, right? Because you obviously have the mixing, like many of the, you know, the gardeners and the security personnel and the domestics and the cooks, you know, these are people from informal villages who go into the more richer areas. There's always a mixing of people, right? And so the disease, you know, would spread, but in a different pattern than in the West, right? And that may have something to do with it. I don't like arguments that go on genetics things and things like that, because, you know, that's an essentialist, right?
Thanks, Harris. I don't see another hand up, but I want to not be provocative, but to reach back, because again, I go with this idea, the more things change, the more things remain the same. Harris spoke a lot about, for instance, vaccine hesitancy. And he mentioned, and Harris, correct me if I'm wrong, but the so-called hesitancy, especially among people of African ancestry. And it set me thinking again about Canadian history, some aspects of it, the smallpox in the blankets. It set me thinking about the Tuskegee experiment in the United States. So and to some degree, I am sure that people have some genetic memory. We might not be able to pinpoint it, but there seems to be some evidence for that. So even though it might be unconscious, but this hesitancy, I wonder if either of you would like to comment, or whether you see any kind of linkage with those aspects of our history, spatial distribution and control and colonialism.
Yeah, I'll let Yvonne go first, and then
I'll just say briefly, because I think this is more Ali's area of expertise in terms of epidemiology. But I would say this in terms of this connection to lived memories and our connections to our histories and our knowledge of what has gone on. You've touched on this. It is not too far out of our distant memory that we were brutalized, experimented upon, the most experimented upon groups of people, especially racialized African ancestored women. Some of the most ghastly, I would say, gynecological experiments, for example, and some of the benefits that women benefit from now were done on African ancestored women, enslaved women, oftentimes without any benefit of pain relief. Most of the gynecological benefits we have now were done upon African women's bodies. It is not a far conclusion to connect the logic of harm has been done to my body historically without my consent. I don't have enough information about exactly what is going to be injected in me yet again. I would say that it is a logical conclusion for people who have that psychic connection to their ancestry to form that opinion, to be reluctant to have needles over which they had little information at the time, if you think about how the information was coming and how little was known about it.
Okay. Thanks, Yvonne. Please forgive me. I really thought that we were going till 2:30, but it's until 2 o'clock. It's 12:30 to 2. So, and Dr. Meander, she has to say a few words before we end. So please forgive my dereliction of duty. Okay, please, Dr. Meander, you're next.
Thank you, Harry. I'm so sorry I connected late because of having trouble with my connection. So yeah, but I was there at the beginning, but late. Okay, I would like first to thank you, Dr. Yvonne and Dr. Harris, for this instructive conversation that reminded us that coloniality is still with us. So the struggle is not over. But in the same time, I have hope. And then we need to keep that hope alive. So by knowing that from the struggle, from the resistance, come victories, achievements, and through that achievement, we can accomplish, we can contribute to the betterment of all of us, of the humanity. And I think at the academic level, I saw Patricia, she already left, but I saw her comment in the chat. And I think at the academic level, by doing research, we will push the institution to have some data, disaggregated data that we can learn from and change maybe the world. By saying that, I would like to thank you, each and every one of you, for attending. This was our last activity for the 2023 Black History Month at the Harriet Tubman Institute. And thank you very much for attending. We could not be able to do all the activity we did this month without the financial contribution of our sponsors, the Dadale Institute, the Research Center for Public Sociology, the African Studies Program, the Faculty of Environmental, Urban and Change, Glendon Faculty, and the other sponsor who didn't give a financial contribution, but helped to build this. I name CERELAC, CFR, and School of Gender, Sexuality and Women's Studies, and all of my executive committee, and my beautiful coordinator, and all of the people who help us. Thank you very much. And I wish to see you next year on the Black History Month activity. Thank you very much for attending.
Yes, and thank you all for having me as your moderator. Blessings to all of you.
Yeah, and thank you, my deputy director, who did all the moderation during the Black History Month. And thank you, Harris, too, for doing this last one.
Indeed.
Okay, thank you, everyone. Take care.
Okay, bye now.
Thank you. Take care. Bye-bye.